sizes. If somebody can guess all of these correctly, there's a bottle of wine in my bag. No, I'm just joking. As the WHO classification, the last one, which is 2005, shows there are about 27 or 29 benign lesions, about 8 or 9 malignant lesions. But most of these are things that I've seen as a junior SHO or as a trainee over the years. So they can all look like mixed radiolucencies or radiopesties in the jaws. We can have cementoblastomas, myxomas, AOTs, ameloblastoma, CEOT, and a recurrent OKC. That just shows that such a wide topic is difficult for me to cover in this. Just look at, I think it's very important to understand how the tooth develops to really understand why these develop and what interaction happens while these tumors develop. We talk about the classification and mainly focus on KOTs or OKCs, depends on which side of 2017 you are, ameloblastomas, and you've got a few cases for discussion. And just to say, this is a 60-minute talk and not a complete guide. So these are lesions that are derived and from tissues which are to do with teeth development and present in the jaw most of the time. You can see any of those pictures previously shown. How does the tooth develop? So we've got dental lamina, which then tips into the ectomesenchyme. There is a timeline and a reciprocal interaction between the neural crest derived mesenchymal tissue and the overlying oral cavity epithelium, which determines when teeth come out, when teeth develop, and how they develop. The main structure is this cup-like tissue on the picture, which has an outer enamel epithelium and an inner enamel epithelium, which forms the enamel. We've got tissue which is formed by odontoblasts called dentin, and the outside layer of the roots, which is called cementum, and all the anchorage around that, which is called the periodontal ligament, which is what holds the teeth in place. The endoblastic epithelium can arise either from the cells of the enamel organ, the cup that you saw, or just remnants or cells which are left behind as cell rest of malices. They can also form within the lining or from the cells that line other cysts, like a dentigerous cyst. The basal cells from the mouth can also form them, and they can also fall down through the layers and get trapped. There is also no tissue like this can go and sit in your pituitary and also can form a craniopharyngioma. So some history is always nice to these topics. The first odontogenic tumor described was a cementoblastoma. The first description of the classification was 1869 by Paul Brucker, and he called them all odontomes. That name stayed for a very long time. The term still exists as odontome, but not everything which is dental tumor is odontome. So this is the last classification, 2005, which is out in Spain. And as we go along, we will touch on the newer classification from WHO. So how do you look at these things? So somebody comes to you, most of the time it's incidental finding. You find it's about to do a root canal treatment, then see this radiopesty or radiolucency, or sometimes they can have symptoms. They can have pain, discomfort, keep moving, numbness. As always, inspect, palpate, percuss the teeth, take a stethoscope if you are looking for a bruise, and check the vitality of the teeth. If you don't know how to do it, you get a dentist to do it. Plain radiography of first line, CT for large aggressive lesions, and MRI are also useful, especially for maxillary ameloblastomas or recurrent lesions. There is a wide differential, and it's very useful to remember that, especially when you communicate with your pathologist or a radiologist, and they would like to know clinical details. Young person, old person, front of the mouth, back of the mouth, upper jaw, lower jaw, is there flex in the radiograph? So they will be very interested because there is patterns to try to know these lesions. Small cysts, enucleate them or excise them and send them off. And if it's very large, take a biopsy. So they start off with the odontogenic keratocyst or keratocytic odontogenic tumor. What names used anonymously over the years. About 5 to 10% of jaw cyst, mainly occur in the mandible at the back. There's a slight male preponderance, second to third decade, and these are characteristically known to recur, and there's a high recurrence rate despite treatment. That's the general distribution, as said. And they can appear like any of these. So if I did not have that heading on the top, my guess would be this looks like a lateral periodontal cyst. That could be a dentigerous cyst coming from that canine. This could be an ameloblastoma, or that could be a massive dentigerous cyst or an ameloblastoma. But they're all in OKC. So radiological appearance, as we just said, is indicated, but not diagnostic. That's such a pop-out. But anyway, these are unilocular or multilocular, usually well-defined margins or scallop margins. Interestingly, they have the lateral expansion is late. They tend to grow through the cancellous bone anterior-posteriorly before they start eroding the cancellous, the cortical bone on the outside, and don't cause that eggshell is much later. They try and grow lengthwise, and then at the later part they could expand. There are certain things like a cystic ameloblastoma would grow more centrifugally. They would get that AP expansion, also buccal lingual expansion. Biopsy is essential for diagnosis. Okay, so the controversy was also in early, I would say, as far as late 70s. People thought, was this a tumor or a cyst? Till 2005, the last WHO, this was the tumor, showed a high tendency for steady growth, and there were some molecular and genetic markers. But they were mainly related to the PAP gene and the syndromic association of OKCs with Gorlin syndrome. So that's the timeline. 71, 2005 goes from cyst to tumor, and lo and behold, it's back to a cyst now. The definition in 2005 said this is a tumor, but the new definition in 2017 says this is a cyst, characterized by thin lining of paracarotid squamous mucosa, epithelium, and some hypochromatic basal cells. But the book also adds that they are, although they suggest it's a cyst, they should call it a cyst again, but this is open for discussion, as they have described in the paper which supports this, and also the blue book. Interestingly, the odontogenic tumors did not have a cyst category in the last WHO, which has been re-added now. They've got cyst in the tumor section, and this is back in that tumor. Okay, what do? I think it's very important to think of the whole patient, as we always do. So age, size, is this a first-time presentation? Is it a small lesion? Is it accessible? And also from a pathologist's point of view, he or she will tell you whether this is a standard OKC or paracarotid lining or orthokeratinoid, which is a better prognosis. Interesting, there's been quite a lot of work and evidence to show that epithelial islands on the overlying mucosa, take that out as part of the removal, especially from Paul Stellinger and about sapphire, which is the reason for recurrence. These two are the main reasons for recurrence. So, same principle. So, the two schools of thought, people thought it was cyst, enucleated, or if you thought this was nasty, difficult to get to, difficult to reach, then resected. So, Hubert wanted me to add some pictures to explain what enucleation and marsupialization was for the audience who did not know. Enucleation is basically like an incision. So you're scooping out, making sure that all the lining of the cyst is out, and as I said, try and take out that overlying mucosa where you've done a biopsy, or if there has been a breach of bone there. This is the enucleation. Plus, after taking the odontogenic keratocyst out, I've taken a big round burr and drilled the bony edges to make sure that no tiny satellites are around. Very large lesions, especially the maxilla or the mandible, can also be treated by decompression. Once the lesion gets smaller, which it does, and it's been proven it does, then you can then excise much smaller cyst with more solid bone present. And the last one is about enucleation and using some chemicals, and the most common one, carnal solution. This man was a Roman Catholic priest and a cytologist. He designed the solution to fix plants, contains a cocktail of chloroform, alcohol, acid, and ferric chloride. Interesting that 1.5 millimeter bony penetration. Especially the mandible, you need to be aware of the contact of these cysts to the iliaceal nerve. And if you leave it for more than 3 minutes, there is permanent nerve impairment. Okay, so just a couple of slides before we finish this showcasing. So one is the 2008 paper from the Canadian Journal, which showed if you scoop this out, take a bar and rub it, and stick some carnoids as well, then you get released recurrence of the non-resection method. Of course, if you chop somebody's jaw out, you won't have the tumor, the pathologist will have it, so there's zero recurrence with that. And that's again confirmed by this more recent 2012 systemic review, which showed 0% for resection, but overall recurrence rate was 23%, and using with peripheral ostectomy and carnoids, they showed 0% as well. Everybody doesn't use carnoids, and it's quite a few hospitals might not even have it. Multiple cysts or cysts happening in young person with BCCs in young person. Think about golden gold, autosomal dominant, with microdeletion at chromosome 9, the long arm of it related to the PAD gene, and it's involved in the sonic hedgehog signaling pathway. Diagnostic criteria for Golden syndrome is major and minor, and it's a syndrome, so multiple organs are involved, multiple cysts, calcified for cerebri, with ribs, frontal bossing, palmar and plantar pits, and all these elements. So we can now move on to the first case. So we have a 68-year-old gentleman who presents with a right-sided lower jaw swelling and mild discomfort, which he feels has been there for several years. He generally fit in well. Previously, he is a taster, non-smoker, consumes a couple of units of alcohol a week. On examination, there's mild asymmetry of the right mandible, normal lower lip sensation, there's no mucosal breach.
Jess, I might give the first question to you. You probably see this the most out of all of us. What's your sort of workup and for this patient generally?
So normally he'd come from the urine clinic and he would, and that might give us an idea of is it tooth related or is it beyond the tooth? The age is 68, so you look at other risk factors involved, so smoking and so forth, you look at tumours and malignancy. But often, as Rahul said, these things are picked up in asymptomatic patient just on a routine OPG. So the first investigation we do would be and based on that then go on to bigger scans and then biopsy at some stage.
So we have some CT. We might go to CT days. We don't have an OP.
Right, yeah, OPG. So this is a OPG of an elderly patient who's fully dentist in the maxilla. He's only got a few remaining lower teeth. There's a multilocular radiolucent lesion in the right mandible, extending from the right body almost halfway up to the radius. So the loculated areas are sclerotic, which indicates that it's a slowly growing process. There's a breach of the superior cortex, which may be indicating there's the occasional infection, just probably causing this discomfort. I'd look for a sinus opening in the mouth, some discharge, and so forth. But immediately you're looking at 3 or 4 things. Ron was mentioning the crevices, but then looking at mesoblastoma. A myxoma would be low on my list, but they'll be there as well.
How would you obtain a sort of diagnosis for these patients?
Well, the first thing I do is get a CT scan to see how much bone destruction there is, where's the nerve, is there any soft tissue involved, and then if the lesion was pretty well contained bone, then I do an incisional biopsy.
And would you do anything different at this point?
I don't think so. It's a little puzzling in the sense that it's some of those lesions don't look contiguous. Now, it may all be contiguous, but just radiographically it doesn't look like that. So I think the CT scan would be interesting. I guess it's all the one lesion, but it just does occur to one that maybe there's separate lesions there.
Would anyone consider intraocular hemangioma on that imaging?
Certainly wouldn't be the first cab off the rank for me, but ultimately it's needs tissue diagnosis. I agree with what's been said. The interesting features for me are that the cysts have a nice sclerotic or opaque rim to them. That indicates chronicity. The other things to look out for is the relationship with the nerve. It looks like it's both sides of the nerve. It's wrapped around the mental foramen, so any biopsy would need to be very aware that in these dentulous patients the nerve floats to the surface, could be just beneath the mucosa. So just bearing that in mind, I'd proceed with a biopsy and arrange some imaging, either a cone beam or a regular CT.
We've got CT scan.
So while making this talk, I went through that OPG, and exactly that's what in my mind, I described it from that mid-ramus level to body. But as we chased up the CT, I found it quite useful. It all looked like that. And as we went up, the ramus, it was involved, the condyle was involved, and there's a bit going into the coronary process as well. I think CT was useful.
Michael, would it change your approach at this point, or was you proceeding to incisional biopsy?
I think you have to manage the pathology, so you need tissue to do that. So I would definitely do a biopsy.
So let's go with the biopsy.
Okay. An incisional biopsy was performed, and this is a representative image of the histopath. What we found was an entirely cystic lesion. There wasn't any solid component, and the cyst was lined by the squamous epithelium with a basophilic basal layer, and there was a lot of inflammation and edema of the squamous epithelium, some areas becoming spindled and giving the suggestion of a stellate reticulum, but not very well developed. And there was a parakeratosis, a parakeratotic type of keratinization. So the differential included an ameloblastoma, but it was favoured to be an odontogenic keratosis.
Ellie, if we were to give you a specimen, usually what's the minimum amount you need to usually for you to make a call?
The more the better. The more tissue the better. Once you're making a hole, when you're taking a biopsy of a cyst, it's important always to have a look at the cyst and see if there's a thicker area. The thicker areas often contain the daughter cyst that would be extending into the tissue. So, once you're making a hole in the cyst, as much as possible. And if you have a look at this, there's just a few points I want to mention. The bottom part where you can see the paracaratinized epithelium, that's fairly typical. You've got a reasonably prominent basal layer, but what you're also noticing is there's a cleft forming between the cyst wall and the epithelial lining. There's a split. And if you look above there, you can see that same split is much more marked. And what happens is that squamous epithelium separates off the cyst lining and gets left behind in the surgical bed. And that accounts for the high recurrence rate. And that's one of the reasons why you go back and do a peripheral mastectomy, or you cauterize the tissue either by freezing it or using carnoid solution. But if you look in the very right-hand corner, as Ben has described, it's very edematous, the epithelium. And that's what you're striving to do as a surgeon when you marsupialize it. You're trying to change the nature of the epithelial lining from being this characteristic paracaratinized epithelium to a non-specific squamous epithelium. And that's what happens with this whole inflammatory process, where the epithelial lining changes from being a paracaratinized to more of a squamous lining from oral mucosa. When you marsupialize it, it gets replaced. And that brings into question this whole debate as to whether this epithelium is truly neoplastic or not.
Because that should not regret it.
If it's neoplastic, you know, I can't imagine normal benign squamous mucosa would overrun a neoplastic epithelium.
So Jess, you got the biopsy now. You got the imaging. What's the next step?
So it looks to me, so this is a cratosis. I probably just question this for history's sake, that whether he had something simple removed. It's got the appearance in different places, whether someone did have a go previously and taken all of it. So this is a multilocular recurrent cratosis. Then the management changes to a more aggressive form, where the only cure for this would be in terms of rather than marsupialization, locular lesion and that form. It's difficult, you're going to miss a few. So my preference would be a jaw resection, appropriate reconstruction.
Anthony, would you would you go down that approach?
Read me. It'd be beyond my experience, to be very honest with you. I mean, the lesions that I've seen in the mandible are large, and there was one fairly recently that came across to RPA. It was an infected, large keratocyst, and we biopsied that and put in a tube and sutured into place to start off with marsupialisation, and I then sent him to an oral surgeon. So I've seen that sort of large lesion, and clearly the advantage of marsupialisation is that in time one can do a much smaller operation, at least theoretically, but I can see the point here, and that this is disconnected in some elements of it, and so it's hard to believe that marsupialisation would work. And it'd also be very difficult to nucleate all of that and believe that you've got it all out, and you'd have a very weakened mandible in any case. I suspect that Jesse is right, but as I say, it's beyond my experience. I've not had to deal with a lesion like that ever.
Michael, anything?
I don't think there's a black and white treatment plan for this, personally. I think that if the patient presented with a pathological fracture, you then steer towards a more aggressive surgical route. If it presented as is, 68-year-old, relatively asymptomatic, sometimes the treatment can be worse than the disease. So starting with a marsupialisation is not a bad way to go, because you can change that plan later on. And sometimes, I mean, I had a great experience with that either, a handful maybe, but sometimes they can really respond quite well.
If you're doing your if you're if you're doing a resection, does that mean, does the condyle seem to be abnormal and all of that? I mean, at what point are you going to stop?
Or the condyles that are good. Then looking at a TM joint rehab.
That then becomes a fairly morbid operation in the sense that one wouldn't expect normal function after that.
There's a question about success of marsupialization. Jess might get you to take that.
Sorry, the question was, how does it work? I mean, I've done it on a few patients, it never works. It just holds off a major resective procedure for a year or so. You do your biopsy, you marsupialize, come back. I've never convincingly seen any evidence that it works. I've never seen a smaller lesion afterwards. Anyone? I was wondering if anyone.
Yeah, no, I think it does work. I've seen many cases where it's shrunk by, almost 100%. You obviously got to choose the case carefully. A case like this probably is not going to be successful because it's multilocular. But unilocular lesions that are given good access, good home care, able to to make sure that it's cleaned up by the patients with a monitoring solution. In my experience, we've seen a number of cases.
I don't use the marsupialization as a curative step. No, would it shrink down to size, get some bone rebuild, and I think it's 12 months later and go back in, you've got a small operation, there's morbidity, and then do it with the traditional ways, carnal solution and mastectomy. And I've followed quite a few of those, and they've done. And they do recur the small events, which treat conservatively.
But it is quite labor intensive, and you have to have that drainage tube sitting there working properly. You can't just do cut out like the traditional marsupial. You can't just cut out a hole because it all bubbles out with rubbish. We need to have a proper drainage tube, and the patient, as I said, has to keep it clean, keep it washed before it can start to collapse.
Michael, if your marsupialization fails and you need to do a resection, how would you recon this? Vascularized, non-vascularized?
Well, it'll be vascularized, but the fibula with a TM joint, there isn't really a good fix for that. The TM joint, the TMJ concept, I think, is the best TM joint replacement, and I know that this isn't about TM joint replacement, but connecting that up to a fibula is a lot of brain scratching. So I might just put in a fibula and leave the joint pseudothorax and follow it up down the line.
Just want to show some pictures.
So, this is what we did. Then over here.
So the mandible, obviously, the small cortical breach you can see there. Going on to the next one. The specimen radiograph, I think, highlights how far upstream the abnormality gets. They're going into both processes. Then grossly, on the next image, so these are serial slices, transverse slices radially along the mandible, showing that there are multiple cystic spaces that don't appear connected. And then next. This is the most superior slice, so this is condyle process here. And histopathology, much like the biopsy, but a lot easier to see, I suppose, and it's well-defined parakeretinized epithelium with cystic spaces containing tracts.
That's what we did.
Ellie, I'm just going to ask, how often would your incision of biopsy be wrong?
I wouldn't know a percentage, but if you only get an inflamed area, you're not going to get the right diagnosis. That's why I say once you're in there, give the pathologist as much tissue as possible, because if you have a focus that's that inflammatory hyperplastic epithelium, you'll get a diagnosis back of an inflammatory odontogenic cyst, a radiculous cyst, paradental cyst, that kind of thing, which wouldn't fit clinically, but you're not going to get the right diagnosis. So the more the better.
Can I just ask you, do you have any concerns about your TM joint? That's the synthes. It's referred to as their temporary TM joint reconstruction for the reason that they know it erodes through the base of the skull eventually. And the word temporary means at some point you need to go back and change it.
I think I'll have more concerns if this was malignancy which will be needing post-operative radiotherapy. Fair point when these things need to be followed up. I have the pleasure of taking one out from somebody's clinical. That's it. Very good question. Is there anything you do to keep that condyle in position? You could just stitch across the neck and they do drop down.
Is he a gentleman that actually wore an upper denture? I'm interested in well, it just interests me that he's had this very sophisticated repair, and is that actually benefiting him? Now, there are other reasons why clearly you want to do a reconstruction. Just because the mandible, clearly if you don't, will swing, and clearly you'll get a hollow area near the angle of the mandible, so it changes someone's appearance. But functionally, he's, from the dental point of view, not very functional with that. And if that does carry risks like erosion and other things, one wonders about it, and whether it mightn't be, as Michael suggested, better to leave him with arthrosis. Now, clearly, but clearly an accurate occlusion here is not important for this gentleman. He doesn't have an upper dentition to marry against. Not sure that I would have wanted to put in an articular head.
Just to change the topic a little bit, in terms of follow-up, Jess, once you've resected them, do you follow that regularly, and if so, how do you follow this patient up?
From the stage we know if it's completely resected,
histologically complete, yeah.
the recurrence rate is low. Sorry, 0.
Yeah.
So from that point of view, but from a dental rehab point of view, implants and yearly x-rays.
If you inoculate them, how often?
Oh, definitely using LPG. And CT scan that occur quite late.
Especially in a syndromic situation, but this doesn't appear to be syndromic.
We might move to the next case. Yeah.
So second part is the bigger topic, these blastomas. So these are the kind of things I'm going to touch about, mainly focusing on molecular biology, which is changed better the understanding since 2014. So word comes from Amir and Blastos. We talked about it in 1827. Churchill named it 1934 as glioblastoma, not the white British. Benign but locally aggressive polymorphic neoplasm contains odontogenic epithelium, has a follicular or plexiform pattern, and it sits in a fibrous stroma. Global incidence 0.5 cases per million, more common in Africa, India, China. Then in the West later, African Americans are 5 times more than Caucasians. Forms 1% of head and neck neoplasms and 11% of odontogenic tumour. I think that number will change depending on where you are in the world. generally, like most of these things, can be an incidental finding, or have symptoms that do visible, most of the back and front. Unicystic can be associated with those unerupted molars, as we showed a picture earlier, and therefore can mimic anything. They could mimic a dentigerous cyst or a large follicle. The same kind of theme, plain X-rays, CT, MRI. I just wanted to show that extra there because the top, it's of the same patient, but the top one looks as if it's a multilocular lesion, but in reality, the bottom darkness is because it's just that bony cortical window, which is formed, and therefore it seems that those are kind of good areas to biopsy because you're not damaging anything. You've got a window there. It's good to take a biopsy from there, and then when you do whatever you want to do to this, take that tissue out. In unicystic, which is a distinct modality, so single cyst, make sure you take the whole specimen for the pathologist, and I'll tell you why in a second. Again, could be any of these things as we said earlier. So 2005, they classed clinical pathologic classification as solid multicystic, unicystic, peripheral, and desmoplastic. And in the malignant, there could be these two. This is hot on the press as the use expression. So this is the 2017 classification where they've taken the desmoplastic out completely as a clinical pathologic, but they put it in the histological side. And the reason they've done that is they feel that there's not much of a clinical significance to that particular nuance there. And as it's rightly should be, metastasizing ameloblastoma is in the benign because it's just ameloblastoma but with a distant met. It's a benign disease with a distant met. Whereas ameloblastic carcinoma is the nasty one, which is cancer. And as I said earlier, the cysts have been added to this classification. There have been few other changes, 3 new entities added to this classification, but this is not the remit of this talk to talk about this. So I'll stick to these original and solid multilocular. This term has been taken out because as the authors feel that it confuses people, they just call it ameloblastoma. So that's the main money shot, ameloblastoma. So people don't get confused. That's the majority, which needs a more aggressive treatment, and the other less common ones are kept separately. So this is more aggressive, more recurrence with conservative measures. Posterior tumors need to be looked at carefully and planned because they can obliterate the sinus and then subsequently breach to the posterior wall of the maxilla and go anywhere in that direction. They've got the poorest prognosis. For these, if you can cut it out, cut it out. Unicystic is a distinct clinical pathologic entity, and it's good that the new classification has taken out all that multilocular, unilocular, very confusing terms for people even who are who know these terms. This is the most benign subclass, and they usually associated with an unerupted symptoms like the picture at the bottom. In younger people, most can be enucleated, and that's what happens. People think this is a small dentigerous cyst, enucleated, send it to the pathologist, and they say, oh no, this is a ameloblastoma. That's Ackerman's description from 1998. He divided this into 3 types, where the ameloblastoma might be typed. Unicystic ameloblastoma might just be sitting in that lining, or 2, if the fronds are poking within the cavity. So these 1 and 2 can be amenable to just enucleation. 3, where there's bits sticking in the wall, or there are tortoises or satellite lesions sitting around. So they should not be treated, and they should be treated more aggressively. Peripheral, not that common. Older people, males more common. This look like a massive epulis. You can take them out, take some surrounding mucosa and a sliver of the bone, and that's good enough for them. Desmoplastic, I just left it because this was in the previous, but the slight nuances, these are more common, the anterior mandible, but they should be treated in the same way as solid or multicystic. But this has been taken out from the 2017 classification. Histology, there are several patterns that the pathologist can look at it, and but not sure whether these have any clinical significance from that pattern.
Henry, do you tend to report based on those subtypes?
No, for me, there's 4 clinical pathologic types of ameloblastoma. One is the conventional one, which is the multicystic and solid pattern. Unicystic. So unicystic is not really a microscopic pattern for me. So the tumor has varied faces, and all that is for the pathologist to recognize there's different possibilities that this thing could look like. A number of years ago, they believed that the granular cell variant had a higher recurrence rate, but I think that's been disproved. So essentially, it's just to inform the pathologist that there's different patterns that need to be that we need to be aware of. It has no impact in terms of management.
So malignant old system called 2 types, but I think the new system rightly calls the first one, which is the metastasizing one, as a benign disease, which is distant met. But the cancer, true cancer, is ameloblastenic carcinoma. They are pretty rare. And when distant mets do happen, the lungs are the most common site, and regional neck mets have been reported with mandibular primary. So interesting changes happened in 2014. 3 sets of people looked at the mutations in ameloblastoma. I was made aware of this by a friend of mine, Peter Morgan and Carl, who was involved with one of the groups in Finland. They looked at BRAF, RAS, FGFR2, smoothen. So the study was to look at somatic mutations impacting the MAPK signaling pathway and control cellular proliferation. All 3 studies report high frequency of BRAF V600E, and the BRAF mutated immunoglobulins are almost exclusively located in the mandible. The cells were sensitive to the targeted molecular therapy, and there has been some small groups of studies which are looking at using this as targeted therapy, especially in association with syndromes. It has also been used for Gallwings and OKCs, and also in some limited ameloblastoma. The other group is the SMO, or smoothened. And it's been seen that the maxillary generally favor the SMO, and the mandible BRAF V600E. They're usually mutually exclusive, but this is definitely something new in a category of a disease that we thought we knew all about for a very long time. Treatment strategy: surgery is the main treatment. There is not much role of conservative apart from the unicystic type 1 and type 2, as we talked about, but it all depends on where in the world you are, what age you are, what your philosophy of treatment is in the US board, and hence there is lack of level 1 evidence. So conservative cushion moves from Glasgow, 2006, big recurrence for conservative. Amsterdam, 50% recurrence versus radical, no recurrence, with no jaw. So this is an interesting paper where it looks at Nabil Saman's paper from Hong Kong, which looks at use of modalities in unicystic. So these all options are valid for unicystic, but unicystic, where it should treat it as enucleation with additional carnoid, showed the least. Generally, radical method is advised with 1 centimeter bony margins. I've put a few references here, and that's the range of, it can all be argued as to what you would like to do in your center with the aim of clearing the disease. It's not cancer, you just want clear margins and getting rid of it. Interesting that frozen section of the soft tissue from the overlying breach is useful, and also if we can curate out some cancellous bone at the edges, that can be useful for, and that's the references for that. So recurrence, that's a few papers looked at together. So if you are conservative, 65% recurrence. If you are radical, and then you chop the jaw, which is on block resection, even then you can get there's no role for radiotherapy. It is being used for positive margins, recurrent disease, and unresectable margins or inaccessible areas. But as the chart here shows, chemotherapy has no role in it. Okay, coming on to our second case, 78-year-old chap again, asymptomatic. The dentist found a incidental finding of an anterior mandibular radiolucency, severe history of ischemic heart disease, had 2 vessels stenting done about 4 years ago. Minimal buccal expansion just on the inside, labely, normal lower lip sensation, and nothing to clear up.
Go straight to the imaging for this case.
So I don't have an OPG, but that's the 3 representative samples I could get of these 2 things.
Jess, I'll get you to start again.
It looks to be a unilocular radius lesion in the anterior mandible that's breaching the outer cortex of the mandible. The roots of the teeth don't appear to be involved in the sort.
How would you obtain a tissue sample for this patient?
So where the lesion is at its thinnest, or where the bone is at its thinnest in the anterior mandible, so I'd raise a thickness periosteal flap from the ginger of the teeth inferiorly. The bone in that would either be quite soft or would be just a small bone, and then take the sample. So all anterior is quite straightforward.
Would you at risk to that teeth with the neurovascular?
No, will be fine. That too small to be done.
Anthony, would you do it differently?
No. I think it needs biopsy, and as Jesse says, if the biopsy level has fission in the lower buccal sulcus, or raise a small flap there, and I think you can biopsy it there very easily.
So go straight to biopsy.
You don't have biopsy?
Biopsies weren't available, but it was reported as showing amyloblastoma.
Okay. So this one, amyloblastoma on that imaging, go back to the CT row if that's okay. Michael, I might start with you. First of all, how would you manage that?
Just looking at the imaging, lingual cortex looks solid. Malignant processes, would traditionally go both ways rather than just buccally, or labially. So there's kind of a intrinsic safety sign there that this is not really aggressive. Biopsy we've discussed, sarcoma style approach, making a decision in an area that you're going to be resecting later. And I think with this sort of case, because it's up front and reconstruction is relatively easy, an en-bloc resection is going to be probably the easier thing to do, particularly with our current reconstructions. Obviously, we'll completely look at the imaging. I really like cone beam CTs. I think it gets such fantastic resolution, expands so clearly, and I'd use the 3D modelling that we have available to us to really kind of optimise the outcome and minimise the operating time.
Would you before you do that, would you do any other imaging, like systemic imaging for this patient? You assume they're on local disease.
No, not if a biopsy. No, a biopsy. I wouldn't necessarily image it. If the patient presented with numbness, it was blowing out lingually, I'd be worried that it was something like an intraosseous carcinoma, very aggressive pathology, and then obviously you go down the CT or the PET route. But for this sort of thing, I think you said the patient wasn't numb on presentation, it's 78. I would go slower.
And your margin? Bony margin?
The figure I always top of my head is 1.5 centimeters, but I don't think any of us get the measuring tape out with these. You take it at least a tooth width beyond the radiological margin. There's no point in putting a patient through this to have a positive margin.
Thank you.
I agree they need a segmental resection one, I mean, what I always went was a centimetre in cancellous bone. If there's intact cortical bone, you don't need, that's a margin. You don't need to go beyond that if there's intact cortical bone. But you really need a centimetre of, I think, of cancellous bone. And clearly if it invades in soft tissues, you need then a soft tissue section that also has a margin. So I think that's straightforward. I think the section is what's required.
Given that it's 78 and it's unicystic.
Well, if it's unicystic, what's this stuff up here?
I think unicystic sort of.
Now, whether that is part of this, I don't know. I don't think the CT scan's good enough to tell us, probably.
The biopsy didn't...
Right at the back of the jaw, around the unicystic clustered around the third molar. This will always be lapping around the roots of those teeth, and it's much harder to get out.
Jess, would you do something different? Would you try something simpler in 78?
Well, the only feature that worries me is, as Mike said, it's going around the roots of the teeth. It's hard to get a margin on, and those sort of multi-loxes of lesions there. But if those weren't there, we could consider a nucleation and watch and wait. There's nothing to do this because it is benign. It's 78. Operation for a segmental would be
If you really believe a meloblastoma is a benign.
Do you have a different view, Haley?
Well, they're infiltrative. Basal cell carcinomas are infiltrative. They don't metastasize. These are infiltrative but don't metastasize. Just playing devil's advocate. For me, these are not truly benign tumours. They're probably classified as borderline tumours. But unfortunately, the teams that treat these know what they are and know their behaviour. But I'm not so sure that these are truly benign neoplasms.
So we'll go on to
Yes. Segmental resection, which is done in our stroke.
This is the specimen after release 6. I think see there's this in the cortex. This surface doesn't look normal. And we go on to the specimen radiology, just showing that cyst again. Perhaps a bit of multinocular thinning securely, then back to the macroscopic, we have a ciliary slice and locally destructive, I think the appropriate description for it. I think there was an image of the whole specimen on the side. This is the very first slice at the left side. I believe you can see that's looking quite abnormal. So this, I don't think this is the on fast of the margin, but this is the opposite side in this photo. But very close, and you can see the anterior, the lingual, sorry, the buccal, and it's getting right through that cortex. This is a histological image of that slice at the on-fast shade of the margin, showing tumour present, and you see that you call it microcystic, with squamous lining and basal cells with a stellate reticulum, not so well developed here, and some areas where there's some squamous differentiation. actually. This is the lingual cortex, also showing that the tumour extends. It doesn't project very well, but the tumour extends right up to the inked margin and punching through that lingual cortex also. So quite extensively destructive.
And is there any sort of controversy in making this diagnosis usually?
If the solid and multi-cystic area if it's only the cystic area that's biopsy, you often, or you won't get the correct diagnosis. You're going to get a non-specific diagnosis, maybe in that kind of location. Lateral periodontal cyst could be the diagnosis. They may be multilocular in the form of a botryoid odontogenic cyst or a glandular odontogenic cyst. It's not the histology of a glandular cyst, but if you only fall into a locule and only biopsy the locule, you're going to get the wrong diagnosis. So that certainly does occur. Seen that on a few occasions. So again, once you're making a whole, please look for the solid areas and curate out the solid areas to submit, because the cystic area is a challenge. Because what happens as the cyst enlarges, the epithelial lining gets compressed, and it becomes nondescript, non-specific really.
I just got a question online. We presented a few options for management of unilocular ameloblastoma. The question is, there a consensus on how to manage a small unilocular ameloblastoma in the panel?
I think that they normally get managed for us, because they normally get diagnosed after the nucleate is. So after it's been extracted, it's been scraped out, and it's sort of it's a post-thought that you make the diagnosis rather than you make it beforehand. But certainly I think enucleation it's very reasonable.
For a small unilocular ameloblastoma and a watchful recurrence. So
yeah, depending on your discussion with the pathologist.
Anthony, that will be your approach, or slightly different?
No, I think that's fair and reasonable, and clearly you want to know that there wasn't the sort of capsule around the thing hadn't been invaded when the whole thing was submitted to pathology. And if that is the case, then I think that's adequate treatment. And you then need to make this difficult decision about how often you follow them. But I guess once a year for some years would be a reasonable thing.
Once a year for 10 years is the standard for ameloblastoma. The only difference would be you'd probably treat it like a paralysis, where you would burn the cavity with kernels of some sort of steroid.
So if your dentist has done the enucleation after extraction and send it to you with that diagnosis, but you're not quite sure whether it's completely treated, partially treated, would you go back or would you watch?
I'll check the pathology for adverse features.
Yeah.
As I said, and then based on that, if it's a variable, then watch it. Because the treatment will be the same. Watch it respect or watch it.
Has anyone had a lot of experience with Hanoi here?
Little.
you.